Good afternoon, good morning, everybody. Selamat siang, welcome to this second webinar of the Indonesia-UK stroke collaboration. Thank you for joining, thank you for making the time. So this is the second in a series of webinars. I really hope you enjoyed the first one on the sharing the primary care systems in our two countries and received the answers to the questions that remained after that. I'm very excited about this workshop because it's really about how do we prepare ourselves with the workforce capable in the right place and the right time with the right skills to meet this huge challenge. And that's what we all want to do. So I'm very grateful to everyone for joining. I'm particularly grateful to Ibu Arianti Anaya, the Director General for the Health Workforce. This is one of a number of areas of work with you and your team. And thank you for all that collaboration. Bapak Laode Musafin, the Director of Planning for the Health Workforce. Dr. Ita, the Head of Neurovascular Division from RSPON. RSPON, such an important center for expertise in the hospital treatment. And all the representatives who've been able to join from the health provision system, from the Ministry of Hospitals, Puskesmas, of course, particularly as we're talking about primary care, representatives from the Collegium and the Council and the associations. It's great to have you. From the UK, I'm delighted to welcome Dr. John Cooper again, our Head of Expertise for this program, and his colleagues from across the NHS system. Tom Petrov, John, who I can't see on the screen just at the moment, our workforce planning experts who will join with you to talk today, and Claire, who you are now getting to know well, who are the key for our program. So we have decided together to really focus on primary care a huge amount in this first year of collaboration. We're looking at the curriculum, curricula, but this element of who do you need with what skills, where and when is critical to anything we're able to do with those skills. So I hope you enjoy today. Please ask questions, put them in the chat. John and everybody will pick them up. Some they will reply to instantly, and some they will, we can answer after if the answer will take longer. So thank you very much. And I will hand over. Thank you.
So if we could go on to the next slide briefly. Just a quick overview of proceedings this morning. And thank you, Zoe. Sorry about that.
John, I can't hear you. Is that just me?
I don't know if anyone else.
I can hear John.
Yeah, maybe you, Zoe. Anyone else can hear me? Thank you very much, Thomas. So brief outline of the order of today with our speakers. So yeah, as Zoe said, really great that we've got collaborative presentations from both our Indonesian colleagues and, as we said, Tom Petrov-Clayton from NHS England as well. And then we'll try and get everything together and try and debust the myths of workforce. And this is about medical workforce, particularly from the UK side. Although we know that stroke is a is very much a multi-professional, multi-agency workforce. Next slide. If we can. And next slide again. And just to tell you who we are, next slide again. I think it was just worthwhile spending a couple of minutes just to recap the program for those who are not familiar with it. This is hopefully a 3-year rolling program, of which we're in year 1. This is webinar 2 of 3, which is really looking at a bit more of a collaborative effort of how we can exchange knowledge of what we do in England through NHS England, in terms of how we have managed stroke care across historically and going forward into the next 5 to 10 years as well. We're really grateful for Deb Lowe speaking last time around systems and service, and today is about workforce itself. This is about strategic advice. So what have we done in the UK? Can we transfer some of the stuff that we've done in the UK, in England, to Indonesia, and how can we provide that technical support? And we're currently reviewing that year 1 context to move into year 2. And if we go to the next slide. So our last seminar, as I've just said, was really around looking at primary care and service. And what we really got from that was some things around language. So the concepts of things like palliative care, and what that means for Indonesia versus the UK, primary care and the structures of primary care, and what that might mean for workforce as well. Education and training, curricula, as Zoe's alluded to, is really important, and how we skill up the workforce, and what workforce do we have, what workforce can we have, how do we cross-skill, upskill that workforce, the use of tech to widen access to stroke expertise, particularly for a population size of Indonesia and a geographical size of Indonesia. And then these concepts of rehabilitation. What does that really mean from an England perspective and an Indonesian perspective? And I think these are really important language concepts that we need to understand and deconstruct, so we can apply those across Indonesian healthcare. Next slide, please. So a little bit of housekeeping. There are no fire alarms because we're virtual, which is always helpful. We are recording this today, so I hope everyone is okay with that. At the bottom, we've got of the screens, we've got some chat function. So if you want to ask a question that everyone can see, that's absolutely fine. And the usual courtesy of raising one's hand is there to ask a question, and there's a Q&A function also. What is really important is to listen to the audio, to listen to the speakers. If you want to listen in English and hear in English, then press the English button. If you want to hear in Indonesian, then please press the Indonesian button and menu for going through the presentation itself. And I think that's the housekeeping done. There will be links to recordings, I understand, going forward. And I think that's it for housekeeping. Thank you. And if we move on to the next slide, I'm ready to introduce slightly early Mr. Musafin, your salutation and details are there, but you're the current Director of Planning of Health Workforce, and you've been Director of Health Training in Makassar until 2020, and at Makassar and Jakarta, and big history in the sort of health office of Indonesia. And I'm happy to hand over to you to give us our first presentation this morning. So thank you.
Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Peace be upon you.
In Indonesia, allow me to share about the policy in health workforce planning in Indonesia. As you know, Indonesia now face much catastrophic disease, and the number of population in Indonesia about 250 is a very, very big health expenditure to tackle these problems. And based on health planning strategic in Ministry of Health, my ministry have decided that Indonesia, especially Ministry of Health, should tackle at least 6 number of disease which is resulting high death rate. One of them is a stroke. Next slide. Indonesia Ministry of Health has launched since 2 years ago the health transformation system. We call it in Indonesia 6 pillars transformation. The first pillars talking about reformation, transformation in primary healthcare. And then the second is about how to transformation secondary health services. And the third one is health system resiliency transformation. To support these 3 pillars, there are 3 pillars is more important, and one of them is how to transform healthcare workforce in Indonesia. Allow me speaking both in Indonesia and English. I have just attended the meeting with the minister, and as I know, the developing of model, how to integrate it from the primary healthcare to the hospital in addressing the problem of stroke. And until now, I see Ministry of Health still looking which of the best model in addressing to solve the problem of health stroke in Indonesia. Next slide. At least we have 2 regulation concerning with the health workforce. One is the law number 17, 2023 about the health, and the others is law number 20 about civil servant. In the civil servant law, there are only 2 types of a government employee. One is permanent civil servant, and the others is temporary contractual civil servant. Based on this regulation, each government in central level and local level agency should obligate to prepare the requirement for the number and type of civil servant position based on job analysis, and workload analysis. They are a little bit different concerning the fulfillment of minimum standard in health workforce based on the different type of health facility, from the primary healthcare to the hospital healthcare. Based on law number on health, law number 17, the central government determine policy and prepare plans to medical personnel and health workforce to meet the needs of the health care reform based on facility nationally, and should coordinate the local government to prepare from the determine the formulation, and then the formation, and then the process of two kind of health workforce: permanent civil servant and then temporary contractual civil servant. In terms of scheme deployment of health workforce based on health regulation, we have three kind of scheme. One is civil servant, permanent and temporary contractual, and then special assignment, especially to fulfill the health workforce in the remote area in Indonesia. And the other ones is other scheme based on modeling and so on, based on best practices from the other countries. Next slide. This is the minimum standard health workforce based on type and number and based on health facility. We have at least 6 ministry regulation about the minimum standard of health workforce. One is Health Ministry Decree number 43 launched in 2019 about the standard minimum in public health center. They should have 9 type of health workforce and then 2 supporting personnel. The personnel who responsible for the IT and the other one for the treasury. And then Ministry of Health also has decided to fulfill the health workforce for sub-health center. Indonesian call it Puskesmas Pembantu. We should have 2 kind of personnel. One is midwife and the others is nurse. And then based on National Medium-Term Development Plan has decided but in the hospital at district level should be have minimum 7 types of medical specialists: surgeon, internist, anesthesia, specialist for pathology clinic, obgyn, and so on. There are 2 types of specialists should be minimum available in the public district health hospital. And then we should have a public health laboratory to bridging the reform in the primary healthcare and referral system. The Ministry of Health has bridging and launched to increase the capacity of community laboratory at all level, in level of health center, level of district, provincial, regional, and then a national level. So based on this regulation, at least, I should pay more attention to ensure that at all level, from the sub-district, village, to the national level, should fulfill with the minimum standard of the health workforce. And as you see, we face many problems about this, the availability of the health workforce. As you see, we face shortage, more than 40,000 health workforce in the public health center, and then the other for sub-public health center in the village level, more than 41,000, and then to fulfill public health laboratory, 2040, and then we also have many problems about how to make each hospital, especially in this, to handle the stroke disease. This is about more than 1,005. Slide. This is a mapping of health workforce need in the referral hospital concerning the stroke. But I noted based on the last presentation, the director respond that until now we at least have many problems, not only at the national level, but also in the district and provincial level. There are problems about how to implement the stroke reform in Indonesia. One is they have running well because medical devices and the health workforce has been available at that hospital. But many problems, even the medical devices has been placed in the hospital at central level, at provincial and district level. But the main problem is about how to fulfill the kind of health workforce, especially for the specialists in each hospital. Next slide. This is the problem about how to fulfill the availability of health workforce, because based on the civil servant regulation, that to make sure the availability of health workforce for the local government is the responsibility of the local government, not the responsibility of the national level. At the national level, we only facilitate coordinating with the line minister to see the fulfillment, the availability, number, and kind of workforce in each facility. We are a new director who are special assignment to create the planning of the health workforce at the national level. And as you see, based on this, the process of recruitment through public health servant, there are many big problems caused the needs for the local government and the fulfillment of minimum standard based on Ministry of Health regulation is still much more gap. The color of green is the minimum standard. In the 2002, 12 to 22, we has decided that the minimum standard should be number is 50 and 1,000, but based on a local government point of view, they are only proposed to the Line Ministry, Indonesia said Kementerian Pan-RB, Ministry of Bureaucratic Reform and Administrative, they only propose 14,000 more, and it's only about 20% from the minimum standard. And the next problem is, even the formation has been opened, but the fulfillment, the workforce who passed the requirement, only a half, only about 800. And then in 2003, the trend is the same. We face that there are different things to catch the problem in fulfillment of civil servant in the local government, especially in the district level. And in this year, we has calculated at least we should propose nearly 100,000 of head workforce based on the 6 regulation minimum standard of to fulfillment the head workforce in each level. Next slide. Oh, this is my last presentation. So sorry, jadi kami masih mengalami banyak.
So we are still facing a lot of problems because of the difference in perspectives from the local government and the national government about the formation of the needs of health workforce in terms of number and also the types of health workforce. And this year, we are still looking for breakthrough how to make sure that the minimum needs based on the Ministry of Health regulation, that we will be on the same page between the local government and the national government. And the next challenge with the stroke care is that there are many specialists that are required, and up to now, we still can't fulfill from the number from all the faculty of medicine here in Indonesia. And based on our observation, only a few doctors who would like to become P3K, because to fulfill the needs or the gap, the government only opens the temporary public servant scheme. Because this is temporary, there will be a difference in the treatment with the permanent public servant, and the Ministry of Health has decided to fulfill the specialist facility. So they are proposing so that they can be made as permanent public servant or civil servant. And colleagues at the Director General of Health Services has got a planning to fulfill the number of specialists in handling stroke, and they've got the plan for the 2024 to 2025 and up to 2027. And now, to make sure that this can be fulfilled and they can be made as permanent civil servant, we are now considering to actually create a stronger regulation of policy. So we need to have the strong regulation. So it's not at the ministry level, but we propose to have the presidential decree or presidential instruction, so it can give mandate to the Ministry of Bureaucratic Reform until 2027. So this should be offered to specialists. We are currently still calculating for the numbers proposed so that we can have the presidential instruction, so that we can fill the gap of the specialists needed,
primary healthcare facility,
especially at the primary healthcare facilities. That is our hope.
Very happy to see expert college from England. I see you have many experiences on this matter, and kiranya itu bisa dapat memberikan pelajaran bagi
And I hope that that can be a lesson learned for us and inside as well in developing the model and also in planning our workforce in addressing the stroke issue in Indonesia. And that's all from me.
Assalamualaikum warahmatullahi wabarakatuh.
Peace be upon you.
Thank you for that really helpful insight into how the workforce is planning, and there's a few questions I think will come in around that, and certainly got a few things to work through as well. Brilliant, and thank you for sticking to time. Really helpful. Delighted to introduce Dr. Itasari from RS PON. Again, good to see you again, and thank you for looking at the sort of stroke workforce planning in Indonesia from that perspective. So over to you. Thank you.
Thank you, Dr. Cooper. I share my slide. Maybe I could share my own slide. Okay, thank you. Good morning for the all participants from the UK, and also good afternoon for the all participants from maybe Indonesia. Today I would like to share about our strategies for this year to about the secondary care in national stroke care transformation, and for the I would like to remain for the early for my presentation that we have national stroke care transformation program. And on stroke, our program was focused on two kinds of stroke. For the ischemic stroke, we must see the hospital have the capability to perform the thrombolysis and also the mechanical thrombectomy. And also the second, for the subarachnoid hemorrhage, the hospital that already stroke-ready hospital must have competency to have performed the endovascular coiling and also surgical clipping. So based on this capability, we have hospital stratification for our stroke-ready hospital. For the first basic is dasar hospital, that the hospital located in the district or cities or agencies, and they have capability for dasar just to perform the thrombolysis. And also we have in the cities or agencies also the Madya Hospital. Madya Hospital is the second line of the stratification of the stroke-ready hospital. So for the hospital also can perform the neuro intervention vascular non-surgical. So they also have performed mechanical thrombectomy, and also for the subarachnoid hemorrhage, the hospital can perform the vascular coiling for the patient with aneurysm. And also we have for each capital of the province, there is hospital as Utama Hospital. For the Utama Hospital, the hospital must have the capability also to perform the vascular intervention surgical. So for the patient with subarachnoid hemorrhage, the hospital can perform the surgical clipping. Based on that, this is our progress of the stroke service in 2023. For the dasar and madya is based on 5/514. So this is the number of our district in Indonesia. So we have 514 madya hospital and also dasar. And for the Utama Hospital, we have 34 provinces. This is the capability to perform the IVT. We see that in the end of 2023, the hospital, we have 39% that can perform the IVT. And for the hospital that can perform the mechanical thrombectomy coiling or as Madya Hospital, we have 11.5%. And for the province that have capability to perform clipping, we have in about 47% province. This is maybe the distribution of the district of that can have capability to perform the IVT. We have 39%. And how a hospital, we say that our hospital capable to perform the IVT, the equipment is just the hospital must have the head CT scan, 64 slides, and also minimal have one neurologist. And for some hospital that cannot perform the IVT, we have 3 categories of the types of the hospital. The first is the hospital, we have 8 hospitals that have CT scan, but still not have a neurologist. We have a coordination with the Indonesian Neurological Association and also the Collegium to facilitate the placement of the neurologist targeting in this first quarter of 2024. And also for this hospital, because we must, the hospital must capable to perform the IVT, also the nurse training for the stroke nurse and also core stroke team training, we will perform to this hospital. And also there are for the second, the hospital, the district that has neurologists, but they still not have CT scan. We have over than 115. And for this in 2024, our Ministry of Health will give this hospital for the Sikti hospital will receive the CT scan in this year, and the others will have had CT scan in the next year. Because we know that our national stroke care transformation is for 2022 and until the targeted in until 2027. And for the hospital that they still not have CT scan of not have neurologists, also some part of hospital will receive the CT scan. Also, we have discussion about the placement of neurologists, because actually for now, for the neurologists, we have currently 14 center of the neurologist residency, and almost then 100 and maybe over than 100 neurologists that can have until after they finish their study in 1 year. And also, of course, for this hospital, post-stroke team training and also nurse training. And for the Madya Hospital, this is the distribution of the capability to perform the mechanical thrombectomy and coiling. We know that from target over than 500, for the end of 2023, we still have maybe of below than 60. And this is maybe we can see the map. And some hospitals, some district that still then they have cath lab, but majorities they have no stroke interventionist. For stroke interventionist, this is so. For the hospital, Madya Hospital, they must have cath lab for the medical equipment, and for the interventionist stroke, they must have maybe neurologists that have fellow neuro interventionist, or also neurosurgeon that have fellow the vascular, or or radiologists that take fellow the radiology interventionist. And for this category of the resource from the stroke interventionist, we know that for the 51 cities, they have cath lab, but still not have stroke interventionist. So maybe for the first category, the hospital have cath lab, but they still not have interventionist. So for the short term, we will think about the drip and drive methods for this hospital. Maybe this is the example, drip and drive. We take some example from the Aceh province. For the Aceh, we can see that there are 3 hospitals, Zainal Abidin, Cutmutia, and also the Yulidin Awe, that the hospital currently have categorized at minimal at Madya Hospital. So the hospital in this 3 hospital, they have cath lab and also have stroke interventionist. So we have maybe how for this 3 hospitals, 3 district, we see how about the other city that near of the each hospital, each city that they currently have cath lab, but now they have no interventionist. So we have maybe some list we can see like Yulidin Awe. We can see that the other city or other hospital that the duration for the hospital Madya to the, we can see Yulidin Awe to Tengkurukan maybe is below is 30 hours. So if they have case for the candidate for mechanical thrombectomy for the hospital in hospital Tengkurekan, we can have some drift and drive. So the interventionist from the Yulidin Awe will come to the hospital Tengkurekan with the team, the interventionist and also the nurse come to the hospital and perform the thrombectomy. we have the we make the cut off time 3 hours, because we know that might be for the transportation or might be for the case for indication for each case. So for other province, we make a drift drive method like this kind of this province. And also the drift and drive methods is the short term, and we have the maybe the doctors in the hospital must have undergoing fellowship on stroke interventionist, and currently some doctors for now have their fellowship. And also we must nurse training in neurointerventionist, and also we will have proctoring coiling procedure that can perform by Utama or Paripurna Hospital. And the second, if some hospitals, 6 cities, they have stroke interventionists but still have cath lab, they will have cath lab in this 2024. And also maybe the large part is the hospital that still not have cath lab and also not have a stroke interventionist. Some hospital with the term will have received cath lab start from this year, and also we have some list or maybe discuss with the collegium or with the neuro association about the how a candidate for the doctor from each hospital that will have a fellowship. And also I think every hospital we must have support from not the doctor but also the nurse, and also if the resource is ready in this hospital, we will have some proctoring coiling for this hospital. And this is the distribution province that capable of clipping. For the clipping, the equipment is the microscope and also high-speed drill, and also there must have the vascular neurosurgeon. For the clipping, the target is the province, one hospital in one province. So we have 16 provinces that capable to perform clipping in 2023, and this is for we can see the color of the distribution. Some hospital have the medical equipment, but without still not with vascular neurosurgeon. So we have a discussion with Indonesian Neurosurgical Society and also the Collegium of the Neurosurgical to facilitate maybe the short training for the neurosurgeon and also perform the teleproctoring. It is maybe for the short term. And also the hospital, the neurosurgeon in the hospital must have fellowship on vascular neurosurgeon. And also for the nurses is intraoperative nurse training, and so they can perform for the treatment for the patient. If the resource is available, we will give some proctoring clipping procedure. And for the hospital, we can see one province that still not medical equipment and also no vascular neurosurgeon. Also, there is still no neurosurgeon in this province. We will discuss, and maybe we will facilitate with discussion from the society to the placement of neurosurgeon, or maybe the final year neurosurgeon resident to this province. And also they will have medical equipment distribution, and also the hospital must have the fellowship on vascular neurosurgeon. We know that stroke is the most comprehensive, so this is our target in this 2024. We hope maybe the capability to perform the IVT increase about from the 39% become 57%. And also for the Madhya Hospital become to 23%. And for the clipping maybe will become 97%. And for the comprehensive stroke service, we know that stroke is not just take treatment the patient in the hospital, but we have must this coordination with the primary health facilities from the screening, from before the patient take patient that have a risk to be before they have stroke. Maybe we some that this screening will be done in the public health center with non-communicable disease. And also we have maybe will stroke risk prediction assessment for this public health center, like mini mental states examination, neurological status, and also ankle brachial index, and also carotid examination screening. For the diagnostic, for maybe we know fast for the how to know the sign of stroke. We have segera ke rumah sakit, segera ke RS. So I think all the maybe the public what must know about this, how to know the sign of stroke. And for the action for the public health center or primary health center must have the primary stabilization and initial management, and also the good must pre-hospital referral. The target is the patient with stroke. We know in the primary health center might be maximal 30 minutes. So if they can go refer to the acute stroke ready hospital. And for the after stroke, we must control the risk factor, and also we know secondary prevention and also community-based rehabilitation. Our another strategies, I think we will develop comprehensive stroke care competency framework to standardize the training for all higher healthcare professional, and also I think the important expands the volume of nurses training program are, because I think in 2023 the nurse training is limited in some hospital. We know that from my previous slide, maybe we focus on the doctor for the how we fulfill the doctor for the each category for the hospital. But we know that for the stroke care, the nurse and also maybe the others like the physiotherapists or maybe the speech language therapists are, I think it's more important. And maybe the next in every hospital we have some maybe some curriculum for this healthcare, other healthcare professional. And also we have like for the funding, we will initiate discussion with insurance. We know that in 2023 we have some top up for the mechanic for every patient that perform the mechanical thrombectomy procedure, but I think the cost is still low, and we will try in this year. And to maybe we hope that the cost for the mechanical thrombectomy cost will increase. And also for the every patient with subarachnoid hemorrhage that perform the clipping aneurysm, also the reimbursement by insurance is still low. So this is also our target in to advocation maybe in this year. And also important to reduce maybe pricing of the stroke medication and also the device. We know that device maybe for the mechanical thrombectomy is still very high. And so also we will for the next, we have some national stroke registry to collect data and also to measure the quality improvement. monitoring and evaluation routine in every hospital monitoring. So the hospital that already might be in the dasar or the Madya or might be the Utama hospital, how about their evaluation of their treatment? And also I think the important is stroke campaign. We must increase, because I think the patient that come in the golden time of the stroke is still might be limited in some cities or some area in our country. I think we know that stroke is significant health challenge in Indonesia. We have some for the effective stroke care requires coordinate and from multiple sector, include health service availability, professional training, and also public awareness. And we have tried to make some progress in our program, and also in some region with the maybe the CT scan and also cath lab and development of specialist training program. And also we have ongoing strategies, including the expansion of medical infrastructure, cost reduction, and also the collective action and sustained commitment from government, healthcare provider, and community are essential, maybe to tackle the burden of stroke in Indonesia. Thank you.
Thanks very much, Dr. Itta, for that comprehensive overview of where we are. And it's actually really good to see some strategic progress actually in the way that you're focusing on the stroke care in Indonesia. So I'm happy now to take some questions from anyone on the webinar. I suppose firstly, for me, if I take Chair's prerogative here, or Chair's whatever the word is, it is really I suppose one for Mr. Musafin, is really how are those numbers of workforce calculated? What's the rationale for that? It's very politically driven from obviously civil servant, ministerial, and have you looked at, you talked about attrition and loss of the workforce, and is there something behind that you've analysed and looked at, and the reasons for it?
Okay, thank you, Mr. John, for your question. Yeah, we only calculate the minimum number and kind of health workforce in each health facility. We not yet decided the number optimum of each facility based on population, based on cases in the hospital. So until now, we only decided the number of, and about attrition, we have developed the information system. We call it SESDMK, information system for health workforce. And then we have more enough database to see the number of attrition, the migration of health workforce amongst health facility. So based on my presentation in 2003, we have at least 4,000 attrition, and then we calculate in this year we have more than 5,000 of attrition. But yeah, I should say we need much experiences from England, how to calculate and to make a modeling from the primary health facility to the hospital based on presentation, Dr. Ita. So it's hard.
And I'm not going to say England is perfect in any way, shape, or form, ever. And there are challenges in this country. And you may or may not be aware, we are from a training and, well, actually a medical doctor perspective in industrial action. So there are challenges around paying conditions. So there's a lot of anxiety within England as well. However, what we do is we seek the thoughts of our colleagues in the workforce to look at what may make working lives better, and it's the thematic approach to how you might look at the experiences people have, what employers might do, so what the hospitals might do. Because what I learned when I was in Indonesia was, each hospital has a different pay and conditions, and in different levels of healthcare within the Indonesian system. So there's a bit of work to do, I think, on that attrition, because the 4,000 or 5,000 out of 91 or so, is a big rate, isn't it? Big rate. I can't see any questions on the chat, but I suppose sorry, I think from your presentation, I think the two striking things are, well, firstly, I was going to say that from the perspective of stroke in the UK and England, we, I suppose, mechanical thrombectomy and mechanical thrombectomy and coiling are two separate bits. So we have neurosurgeons that would do the coiling and stuff, but we have a credential pathway that allows neurosurgeons to train in mechanical thrombectomy and coiling. But the thing for me is still about access. How do you get there? How do you've got public aware, you've got a plan for public awareness, but there's still that issue around access and people being aware and being able to access places that can deliver in a timely manner. And it's again, we look at, in England, we have ambulances, we've got a paramedic service, so you ring up, you call for an ambulance, they whiz you off. We calculate times to transfer based on something called isochrones. How long will it take you to get to a center, and which center? You've talked about time levels, and it's that geography for Indonesia that I think is the big one for me. I don't have a solution to that. Okay, so there is a question here. So to Dr. Ritter, how about drip and ship methods in Jakarta itself? For example, RSUD Senkarem has a cath lab but still doesn't have any neurointerventionists. How are you going to manage that?
Okay, thank you. Actually, maybe I think the one important is also how about it's the local province, from each province to maybe how about they care about the stroke program, the national transformation. And for the Cengkareng is one hospital that in the west side of the Jakarta. Currently, in the last December, we have for now meeting with the government of Jakarta to build the system for the stroke care referral system in Jakarta. And like for the Cengkareng, for the drip and drive methods, I think Cengkareng have the cath lab, so we have some stroke interventionists in Jakarta, like the first we have from Tarakan Hospital, and also we have from the Fatmawati Hospital for the Pelni, and also for the National Brain Center. So for this, we have some optional for the some neurointerventionists. So for the Cengkareng, for now, for the drift and drive, we have some option for the how about the resource to come to the Cengkareng. So if the Cengkareng have the cath lab, like example, we can have interventionists from the National Brain Center that go to the Cengkareng, maybe by over than about 1 hour by the toll road like that. So we will still thinking for the each province. And for the drip and drive in is one methods that we think about with our team. How about, we know that Indonesia is very large and have every province and also every city have their own characteristic. If we, and this drift and drive, we still might be discuss and consultation. We still propose to maybe our the Minister of Health, and the next how to maybe for the stroke care, so the patient will that need the treatment can maybe and waiting for the doctor get the study. So we must, how about if the patient in the this district have the problem. So it is one of the our thinking about still our methods to fulfill maybe the stroke treatment. And for the interventionist, maybe Dr. Deb just asked me, we have for neurologists that, but the neurologist must have the fellow 1 year on intervention. And also we have from the radiologist, neuroradiologist, so the radiologist must have fellow 6 months to become the neuroradiology interventionist. And also from the neurosurgeon, they must have the fellowship about 6 months in the vascular. So we have maybe 3 kinds of the specialists that can perform the become the stroke interventionist like that. We still make some, maybe that about the Cengkareng, we still ongoing, and I think Cengkareng is in Jakarta, so I think it will make soon we will be provide for the drift and drive.
Okay, thank you. I'm going to take one more question. I realize, Tom, I'm going to slightly step over because I realized there's a question and answering bit, but I'm sure we'll be able to catch up later on. So one of the other questions we've got is, what is the strategy and work plan of the national and local government to engage and make the most out of the capacity of the privately owned health providers, which are multiplied in numbers, which are bigger in numbers than the public ones, and also partners the national health insurance?
The first, yes, for the first of the national stroke care transformation, the target is maybe because we have over than 500 cities, and the cities we know minimal in the one city have one public hospital, and we know also they have maybe some private hospital. So the target from this program might be in just one hospital in each city and just public hospital. But for the since 2023 might be the first, because of the thrombolysis, the IVT drug. We know that 1 year ago the drug is get reimbursed. So we know that many that private hospital that now perform the stroke care. We have so many hospital with private hospital that also have maybe for now they increase their treat of the stroke treatment. And also not we know that all the patient with the national health insurance, we know that majority of our patient is national health insurance. And once because of that, because for now, like the drugs is now covered, and for the mechanical thrombectomy, there will some increase for the reimburse. So for now, not only the public hospital, but we know that the private hospital also increase the rates for the stroke care for now. We will ongoing to collaboration between the private and also the public. So our target is in every cities, if maybe the public is still low, and they have the private hospital, we will go collaboration with the private hospital. Is that?
Thank you. Okay. In the interest of time, on both sides of the world, I think we'll move on to our next speaker, who is Tom Petrov-Clayton, who's Deputy Head of Workforce Planning for medical and dental workforces within NHS England. And Tom's worked for the Department of Health and Social Care in the past, and has worked in Health Education England, now NHS England. And I know Tom reasonably well from work that we've done in various work streams within medical workforce within the United Kingdom. So Tom, delighted to have you here, and over to you. Thank you.
I just ask that you can see my screen.
Yes.
Okay, super. So hi everyone, my name's Tom Petrov-Clayton, and this afternoon I'm going to be talking to you about population and demographics in England first, and then subsequently I'll be talking about how we do workforce planning for neurology and stroke medicine. Now, in the first part of this, I'm going to be taking you forward into the future of our demographics. So I'm going to be talking you through how our demographics are likely to change as we go into the 2030s and the 2040s, and we do plan over that kind of time horizon. But before I can take you forward into the future, I have first to take you back into the past to explain why things are likely to look the way they will as we go forward into the 2030s and 2040s. So if you can see this chart, this shows the number of births in the United Kingdom over the last 100 years. Right? So what we find when we look back at our historical demography is that there are 2 points at which the number of births was elevated. So the first of these was in the immediate period following the Second World War, and the second of these was in the mid-1960s. So we have a peak here in 1964, over 1 million births a year. Following that, we have a period of decline. So why did we have a peak in the 1960s? And it's largely because this was a period following the post-war reconstruction in the 1950s, but prior to the introduction of oral contraceptives. So we see an increase in the number of births up to 1964, because in 1961 we had the first introduction of oral contraceptives. Yeah, after a few years they became widely adopted, and we saw the number of births start to decline. Then subsequently in 1967 we had the passing of the Abortion Act, which legalized abortion services, and that also led to a very sharp decline in the number of births from that point. So the effect of these historical demographics has been that there are a very large number of people in the UK now who were born in the 1960s. Right? And this is a population that is now in its 6th and 7th decade, and who over the course of the next 20 years will collectively age from their 50s and 60s into their 70s and 80s, all at the same time as one another. So there's a real demographic crisis on the way over the course of the next 20 years, and I'll be explaining that as we go. This second page shows on the left-hand side, the population density of the UK. And what we find is that there are very large disparities in the population density of different parts of the country. So we have geographies like London here in the dark blue, or places like Birmingham or Manchester that are very densely populated geographies. And at the same time, there are much more rural ones, places like the southwest of England, or Wales, Scotland, and Northern Ireland, where population density is very much lower. These are much more rural parts of the country. Now, the reason we talk about population densities is because of the effect that urbanization has on age demographics. The map on the right-hand side shows us the proportion of these populations that is aged 65 years or above. And the areas in green tend to have younger populations. So, for example, East London, which is the youngest part of the country, has 1 in 10 of its population aged over 65. West London has a population that's more like 1 in 7 or 1 in 8 over 65. In Cambridgeshire here, it's 1 in 6. In places like Cumbria, it's 1 in 5. And then in the southwest, the most rural part of the country, it's 1 in 4 of all people is aged over 65 in these areas. Now, these demographics are set to change very substantially as we go forward in time due to that very large number of people that were born in the 1960s baby boom. I'll be showing you that now. Right, so this map is going to change color with each year that goes by. Changes towards blue represent increases in population, towards orange, decreases in population. So as we go forward, and you can see the year up here at the top, the population of the UK is likely to grow, but that population will grow most rapidly in geographies like the West Midlands here, and in general in England, whereas population in other parts of the UK, like Wales and Scotland, is likely to decline as we go forward in time. Right, so that's the overall population, which is one way of looking at things. What we then do is we look at how that population is likely to change as we look at different age demographics. So for example, and I accept this one isn't too relevant to stroke, if we look at those aged between 0 and 9 years, what we find is that the number of children living in the UK is likely to decline quite substantially as we go forward in time. Right, so the fertility rate of the UK is now below replacement, and has been for some time. And we're not seeing the replacement of children aging into their second decade with babies. Right? So we can expect there to be fewer children as we go forward, with the exception of a very small number of geographies in these parts of the country, but in general, fewer children. On the other end of the spectrum, if we look at the population aged 65 years or above, what we find is that that population born in the 1960s is said to age very substantially into the 70s and 80s, and with that we can expect to see a very substantial growth in the size of the population across the UK that's aged 65 or above. So to have a sense of the scale of this, a geography like London might see growth of between 55 and 60%, more over 65s than they have at present. Other parts of the country may be growing between 40 and 45%, and others, generally in the north of England, where we see slower population growth altogether, maybe between 30 and 35%, as compared to the present. So very rapid growth in the number of older people across the whole country, but especially in places like London, where right now they don't have very many. This is the chart I showed you just a few minutes earlier. This shows the proportion of these populations that's aged over 65. And as I said, geographies like East London, 1 in 10 of their population is over 65. In West London, 1 in 8. In more mixed populations with both urban and rural populations, it's between 1 in 6 and 1 in 5. And then in the most rural parts of the UK, places like the southwest of England or Wales or some parts of Scotland, it's more like 1 in 5 at present. But as we go forward, what we're going to see is that geographies like West London are more likely to look, so geographies like East London are more likely to look like West London. West London is likely to look more like Cambridgeshire, Cambridge like Cumbria here in the north, Cumbria like the southwest, and you know, if the southwest of England of the 2040s was to exist today, it would be one of the very oldest parts of the world. So it would be at a similar level of agedness as rural Japan or rural South Korea, with 1 in 3 of all people living in the southwest or in Wales being aged over 65 by the time we get to the 2040s. So Aging is a real concern for us in England, and it's something that we're designing our workforce around. Just to get a sense of the overall picture here, and this is just for England. As I said, we have decline in both 0 to 9 and 10 to 19 age demographics, and we have a very substantial increase of something like 40% in the number of people aged over 65. The working age population is growing relatively slowly, but is still growing. Right, so we have growth of a few 100,000 people in the 20 to 39 bracket, and again, a few 100,000 people more in the 40 to 64 bracket. England is the part of the UK that's growing best in terms of its overall population. If we were to compare that with Wales, we actually have a declining population with much more substantial decline in all age demographics, except for the over 65s, and a similar story in Scotland with decline in all age demographics except for over 65s. So this requires very careful workforce planning if we're going to meet the needs of an aging population. And I'm going to be talking about that in just a second. In fact, there's one more thing to do here. So this is that population in England broken down into 10-year brackets, because I talk a lot about over 65s. But what I think it's useful to focus on is the number of people in the 70 to 79, 80 to 89, and 90 plus brackets, because this is, I think, a very useful way of thinking about it. Right now in England, we have around 4.8 million people who are in their 70s, 2.4 million people who are in their 80s, and 500,000 people aged 90 or above. But as we go forward, we're likely to see quite substantial increases across all of these, especially in the very oldest age categories. So a 35% growth in the number of people in their 70s, a 58% growth in the number of people in their 80s, and 93% growth, right, increasing from 500,000 people to 1 million people aged 90 or above by the time we get into the 2040s. Okay, so it's a very serious concern for us. Now, I'm going to show you very briefly, this is inpatient internal general medicine. This is just a quick example of how we look at these kinds of activity. So this is the profile of patients who are seen in inpatient general medicine services over the last decade or so. And what we find is that there's a strong skew towards older patients. The modal patient in inpatient general medicine is someone in their early 80s, right? And there are fewer patients being seen in their 90s or above, but that's because there are fewer of them. What we then do is we calculate the age-related rate of attendance by age category. And for inpatient general medicine, this is a chart that looks like this. Okay, so if we look at the rate of attendance per year, each 90-year-old uses around twice the healthcare in inpatient general medicine as an 80-year-old. Each 80-year-old uses around twice that of a 70-year-old, and each 70-year-old around 1.5 to 2 times that of a 60-year-old. So as people age, they tend to consume very much more healthcare than they did when they were young. And in the UK and in England, we have a very rapidly aging population. I'm going to show you what that looks like for stroke. We have a very similar picture. So this is each category of stroke we have in our database. And we can see by the age of the patients who are having these strokes and having these strokes diagnosed, how many strokes there are by each age category. And yeah, again, what we find, as we saw with internal medicine, is that as people age, they become very, very much more likely to have strokes. So as we saw before, someone in their 90s is around twice as likely per year to have a stroke than someone in their early 80s. And someone in their early 80s, in fact, much more than twice as likely than someone in their early 70s to be having a stroke per year. We can then project the number of strokes in each part of the country. And we get charts that look like this. So we can see, this is by 2030, how many more strokes we're likely to see in each part of the country based on the changing demographics of those places and the rates at which people have strokes. And as you can see, the parts of the country that are growing more slowly, like the north of England, are still likely to have 21% more strokes by the time we get to the year 2030. But in geographies like London, that might be 31% more strokes than they have now. So we're likely to see quite substantial increase in the number of strokes in England, especially in those parts of the country that have more rapidly growing and aging populations. What we then do is we take data like these and we incorporate them into statistical models that we use for allocating resources. This is an example of one of those models. So this is how we allocate training places for neurology and stroke. So what I just showed you around the projection for activity in stroke services accounts for 40% of this component in the model. And we have other components that look at other aspects of neurology and stroke care. So here, again, it's around 40% stroke. This one looks at general secondary care services. And we have a third component here that looks at highly specialized services happening in highly specialized, what we call tertiary centers, which tend to be in geographies like London, but are also in places like the Northwest as well. So we can see exactly how much activity is happening in each one of our hospitals and how specialized that activity is. And then we can incorporate that into our formulae to best meet that need in each part of the country. So we end up with this, what we call a distributional guide as to what we think the fairest share of those resources is in each region in England. Then finally, what we do is we compare that distributional guide with where we are actually training neurology doctors now. And what we find is that it's not always aligned to what we think is fairest for the population. So for example, London very often has a few too many. And in this case, a geography like the Northwest has too few. So we take posts away from geographies that are a little bit over-resourced for the populations they serve, and we add those posts to geographies that are under-resourced. So here we're taking 7 posts away from London. We're taking 3 away from this geography called Yorkshire and the Humber, and we're using that to expand in geographies like the Northwest and in Kent, Surrey and Sussex. This also informs when we do have additional investment from the Treasury, where we put those additional posts. And you can see here that we're adding 1 post into the Northeast in the year 2024, and that's enough to offset the 1 post that we're taking away, leaving them where they are on 12 posts in total. So yeah, this shows how we look at the medical workforce. Where we train doctors is aligned to patient need in each part of the country, and that we're always looking at adjusting where we train doctors to reflect the changing demographics and the future demographic trends that we can expect to see in England over the course of the next 20 years. As I said at the start, it takes a very long time to train doctors in the UK. I think we have the longest training programs of any country in the world. So we need to think much more long-term than most countries need to. We need to think about the 2030s, the 2040s, because it takes such a long time to train our doctors. We need to be thinking about the need that will be there 20 years from now, not just the need that's here today. And hopefully I've given you an initial guide as to how we look at that kind of work and how we plan for the workforce of the future. Thank you very much.
Thanks, Tom. And thanks for getting me back on time in terms of sharing, as always good to hear that presentation. So let me just have a look at the questions and answers. I can't see any questions for your presentation just yet, unless I'm let's have a quick look. It's an Indonesian question. We'll come on to that in the overall questions and answers at the end, I think. So for me, Tom, do you want to talk to briefly to the methodology of this, because this is a very different process to Indonesia, as well, in terms of how there are I think training is very academic based before going off to work in an organisation, in a hospital at various levels. In the UK, as you say, we have a very long training system that I think with reform may change over time, with medical reform that we're seeing at the minute, aligned to the sort of mandate of long-term workforce plan. Is it worth just talking through that, because it is a complex thing, but it is a methodology and it is interesting. I think signposting that might be quite helpful.
I'm very happy to share lots of the documentation we have and how we do this kind of work. So in England, we have a system of allocating resources to each part of the country that has been in place now for 30 years. And there's a team at NHS England that's responsible for constantly looking at the demographics and the population of the country and making sure that they send appropriate amounts of money for the delivery of healthcare services to each part of the country. So maybe I can share in the chat, I can share the allocations formula that they use. I don't know how applicable this would be to the data that you use in Indonesia, but I can share, it's all in the public domain, how all of this works. So if I just share this link in the chat, you'll find NHS England's allocations formulae and how much money they send to each part of the country in each component. We use the same formulae in terms of how we work out current need, but we in workforce planning use a different set of formulae for calculating future need. Right? That's where we look at long run demographics out to the 2040s, and we combine that on a medical specialty by medical specialty basis with what we think the future demand of those services is going to be based on how people use those services now. Right? So in some areas where we can see that, for example, in pediatrics, we have a childhood population that is in decline, and so we're not adding huge numbers of extra posts into pediatrics. But in other areas that we think are exposed to the UK's aging population, specialties like geriatric medicine, stroke, neurology, we are adding many more posts to manage that. Now, medical training in the UK, I think happens very differently to how it happens in Indonesia, in that medical training at postgraduate level is done generally in hospital settings. Right? So we have a series of training programs that are run by NHS England and that doctors can apply to through an open national competition. That you are then trained almost exclusively in hospital contexts. There's no kind of academic component to that. They're not going to universities. It's all done in hospitals, being trained as they work. But they are trained to a defined curriculum. Those curricula are produced by our Royal Colleges, and they're approved by our medical regulator, the General Medical Council. So doctors are trained to those curricula. Each medical specialty has its own defined curriculum, and the training progression of those doctors is assessed on an annual basis by their more senior staff. And we in our team do a lot of work to track how doctors are behaving in the labour market. We track their progression through training, and we can see areas in which doctors aren't progressing in their training as quickly as we would like. But we have really very good data on the medical workforce and how it behaves. Maybe another time we could talk about how that medical workforce supply work happens.
Thanks, Tom. Yeah, and I think it's just sharing what we do to see if it'll stimulate some thought across the world to see if it might look at how people think differently around that way of working, and I think that fundamental difference of training in service delivery, in actually delivering day-to-day healthcare, is a very different system, and again, it's not here to define what is the best way of training the workforce at all, but just describing how we do it. It's 9:37. I do have another question in the chat for our colleagues in Indonesia. So this is an Indonesian question from earlier, but kind of about the NHS English version from Google Translate. Okay, so many research results show that stroke patients who come to hospital by ambulance arrive much more quickly in the emergency room. But the facts on the ground are that more than 90% of patients in Indonesia arrive using private cars. How can the pre-hospital system be developed in the UK that so that patients come to hospital using ambulances? Who are the health workers in ambulances in the UK? Is it nurse or paramedic? I can answer that actually. So what we have is we have a multi-professional workforce. We've got quite a diverse workforce that has diversified over time with new professions, and we are continuing to develop professions. The political challenges of developing new professions cannot be underestimated. So we have a paramedical or paramedicine workforce, and these are skilled practitioners who don't just drive ambulances. They are more skilled than that. There are some technical paramedicine workforce who will drive the ambulance, but they are skilled to do very early intervention healthcare at scene. So if somebody has a myocardial infarction, there's in the UK, a 999 call. The ambulance service will go out, see the patient, assess the patient, provide first contact intervention, and bring people to hospital. So it's a very, very different system. You saw from Tom's slides the size of the UK in those regions that that the NHS England is divided up into 7 or 11 regions, I think you described there, with a population size of 75 million. You know, when you look at the geography, provincial, district, and length of and breadth of Indonesia, with a population size of 270 million, you know, it's a very, very different ask, and so it's a very bigger problem. And some of the things I'm thinking of to look at support really is you know, do you deconstruct things into provincial and regional networks again? And we talked about networks last time. You know, you've talked about how you might do the networking within a mechanical thrombectomy bit in the Jakartan area, and I think that's the way I think you could probably gel together everything in terms of resource and expertise and timing, equity of access and equitable access. So that's the UK system. From our visit to Indonesia, yeah, you don't have a paramedic or an ambulance service in the sense that we have. And I don't know if there's any further comments that you wanted to make on that for that question, Dr. Sari or Mr. Musafin at all. It is what it is at the minute, isn't it? I suppose. Okay. Let me just check the board and see.
John, I was going to answer a question that I think Liz Profina put in the chat.
Yeah, I haven't seen it. Yeah,
it's in the answer section now. So Liz, it is the case right now that workforce demand in the UK is higher than supply. Right. So over the last few years, we've been working on a workforce plan that would help address those issues of supply shortage in the UK. So I put a link in the beneath your question to the long-term workforce plan, which was published in June of this year. The workforce plan, which we've done between ourselves, the Department of Health, and the Treasury, has involved very long-run, again, population and demand projections, and on the basis of the modelling that we've done, the UK or England is going to double the number of doctors it trains per year at undergraduate level. So we currently train 7,500 doctors per year in England. We are going to increase that to 15,000 doctors per year by the year 2031. So this is being phased over multiple years. The first expansion from the present 7,500 is going to be in 2024, which is this year now. Then more in 2025, 2026, 2027, until we're at 15,000 intake per year. This is obviously enormously more than we currently have, but the scale of the challenge facing the UK over the next 20 years, I think, really should not be underestimated. Aging populations, certainly in our experience, tend to consume very much more healthcare than do younger ones. And as I mentioned, our population is aging very quickly. So yeah, we have a supply gap now. That gap is likely to become much, much more profound as we go forward in time. And that's why we're increasing very dramatically the number of doctors we train per year. This plan is going to be reviewed every year to make sure that we're on track, and also to review the statistics that we've used to make sure that we're keeping all of that as up to date as possible, and that we have the clearest possible picture of future demand. So yeah, those numbers might be adjusted, but we expect that by 2031, we'll be training twice the number of doctors that we train now. And that's all about meeting future demand needs.
Thanks, Tom. And there's another question, challenges of working, planning and relationship amongst the 7 NHS regions. What are the lessons that you may have learned out of your experiences? I mean, I can talk to that after you, but yeah, I think
it's a good question.
It is a good question.
So I'm talking specifically about postgraduate medical training, right? So, and this is work that we've only started doing relatively recently in the past few years, actually really starting to dynamically adjust the number of doctors that we train every year in each part of the country. Before we started doing this, we found that there were differences in the number of doctors that we were training in each part of the country that weren't always very well evidence-based, right? And often we would find that geographies that were, geographies like London, which is a very rich part of the country, were training many more doctors for London than was the case in other generally less well-off and more rural parts of the country. So when we started doing this work, the response we got from London, who we were going to remove resources from, was, it was not entirely welcoming, and they weren't very happy that we were taking resources away from them. But they accept that other regions need that money, need those training places more than they do. Right? So we've managed to work with London to convince them that it's reasonable for them to have fewer training places than is the case in other parts of the country. And we've moved those, we are moving those now to generally poorer and more rural parts of the country to train doctors for those populations that we think are greater in need, especially in the long term. I think it was very difficult, I think, to persuade, better off parts of the country to have a reasonable amount of the overall resources. But we did manage to get there through lots of dialogue and conversation with those. So yes, we have London and places like Oxford are accepting of the need for them to have slightly fewer resources in the short term, if that means that we can train a larger medical workforce for more rural parts of the country.
Thanks. On a sub-NHS regional level, which is my job, I suppose, at the detail of each individual hospital or general practice or hospice, it's making sure that it fundamentally comes down to the relationship you have with those organizations and money, and making sure that people can afford to take on that expansion, that extra amount of training, because the NHS is probably, I'm going to say, is probably under-resourced for what it needs to be able to do in its ambition to deliver. So I think it is about it's also saying that, yes, we can do the numbers and this is where we need to put doctors in training, but actually it's the experience and the encounters they have at that level as well. And that's back to the attrition bit, you know, about the experience that you have as well. And that's really important at the end of the day. We've got a question from Grace. As a trainer for 112 emergency call centers in Indonesia, yeah, absolutely. The ambition is to be as comprehensive as 999 in the UK. Although, as I said before, I think looking at the geography, you know, do you explore, you know, deconstructing it to a sort of geographically defined area to make it more manageable. Grace is interested in the previous explanation of a driver who can do first help. How do you identify and train this kind of workforce in the UK? And usually the personnel coming from a fresh grad or specialty medical training. So paramedicine has evolved over time. It again has its own college that sets a curriculum, and you will work in at different levels of paramedical training. And there is sort of technical support. So you might not be a paramedic, but you might be a paramedic technician, which might do something slightly different from the paramedic. But it is very much a training program. If you look at the work we've done through the stroke specific education framework, I can't remember if the paramedics are on there yet. I think they are, but that defines the knowledge, skills and capabilities relevant for stroke medicine related to paramedic. I know in the US that they have looked at paramedics actually delivering thrombolysis. The technology is far more advanced now in terms of artificial intelligence, but also in terms of the capability of doing a sort of mobile CT scan. There are data out there to look at this. I'm sure you are aware of that. But I think, you know, the paramedic training pathway is there. It'll be widely, freely available to the public. If we can find some links to that, I'm sure we can share that with the group as well for information as well. So I hope that answers that question.
If I could just add to that, John, it also is part of the long-term workforce plan.
Yeah.
For England, we're expanding the number of paramedic training places from 3,300 per year to 4,000 per year by 2031. And we're going to be directing those training places to universities in parts of the country that have the least good resource right now. So we're looking at where we're currently training paramedics and making sure that we're training more in the parts of the country that need them most as we add 700 more places per year.
Well, thanks, Tom. Man with the numbers, you know, all the detail. So brilliant. Okay.
I think we have a question from Fritz as well.
I haven't seen that one.
Oh, he has his hand up.
Yes. May I?
Yeah.
Yeah. Can I ask in Indonesian? Because my English is not fluently well. Okay. Stroke merupakan penyakit
Stroke
yang
is a disease that causing death and also causes disability after the stroke. What you deliver, what Mr. John, Mr. Tom, Pak Laode and Bu Ita deliver, in which the management of stroke should always be updated in terms of the skill of the workforce. In one term, the management of stroke need facilities, and we also have the fulfillment of human resources in terms of quantity and quality. Also, there is an opinion of my opinion that the management of stroke in Indonesia that is delivered by Mr. Jom is very good. It's related to the people, well-educated people, but in Indonesia, mostly the education is still under average. Moreover, in my region, in East Java, in Jember, the main problem that we face is that the citizen doesn't have any knowledge about the symptoms of stroke. So we actually wish that the stroke management could be soon being managed is becoming a failure because of the lateness of the golden hour. Because sometimes they need agreement from the parents, they need agreement from the children to go to a better hospital, and also they need like a transport facilities which is outside of our clinical ability. And most of our job is about how the citizens are well educated. And in my opinion, as I observe in our community in the first public healthcare, there are two efforts that we find difficulties in. First time is the individual health effort, and then the first one is about the individual side, and then the second one is around the community. If I may suggest, we have now here the Ministry of Health and then the accommodation. May I suggest that in my puskesmas, please give more the effort of a community public effort in which we may have screening of stroke, of like the screening of diabetic, hypertension, and so forth. So when the information of our workforce in terms of the mitigation of stroke strike, if we have a good mitigation, so the number of the stroke will be decreased. So prevention is better than. But however, if we see the proportion of the cost of the budgeting in my region, the number of the cost is more onto the individual curative health effort. So in my opinion, it is good, but for the first public healthcare, they should give a more budgeting for the community based on the prevention level. That is what I want to deliver. So maybe in my region, compared to the other bigger cities like Jakarta, or maybe even compared to England, our place's condition is very different. Yeah, I think that's all I want to deliver. Jadi,
just wants to say a couple of words before we go and we'll bring back that question.
Okay.
If we've got some time. So yeah, it took a little bit of time to get through that question, but we will answer it. Have we still got Arianti at all? Ah, she's gone. Okay, so sorry. Right, we'll try and answer that question then. Do we have a translation? But if not,
yes.
we can get the translation and we can answer that question going forward. And Grace, yes, we can send a link to any paramedic related material certainly there's a lot available. Okay, I realise that there's a lot of discussion to be had. Please send in more. Please send in more questions if you have any for myself, Tom, the team. I think there's still a bit of work to do. Apologies to Dr. Bharanthi for not getting her time to say goodbye or hello. I feel terrible, but there was a big discussion, so I'll chat to her going, or we'll let her know going forward. There is a survey to if you to give us feedback. It's always helpful on this. And again, thank you for your time. Thank you for the questions, and hopefully you found this really helpful. Thank you to Dr. Sari, Mr. Musafin, and Tom, as always, for presenting. And have a good evening in Indonesia and a good day in the UK. It's only just begun, and it's very cold here. Woolly jumpers. So take care, everyone. Thank you very much, and speak to you soon. The next webinar is going to be in February about prevention. So look forward to that. Brilliant. Take care.
Thank you.
Bye now.
Thank you, John. Thank you, Tom.
Take care.
Thank you. Bye-bye.
Sari, sukses.
Bye.
Thank you.